Hello. Feel free to take your seats. For those of you standing, make sure you're comfortable. My name is Janet Walsmith, and I'm thrilled to be here to introduce you to the 20th Annual Neurological Symposium from the McCourt Foundation. So this event really embodies our mission of striving to cure neurological diseases while empowering communities to build a healthier world. We have a bunch of thank yous that I want to prioritize out of the gates. I want to thank our sponsors for stepping up and making it possible for us to offer this for free for everyone. I also want to thank our partner nonprofits, including the Boston Home and the Brigham and Women's Alzheimer's Research Team, who are out in the lobby. So make sure you visit the tables of our sponsors and our nonprofit partners. I want to thank our hospital partners, Brigham and Women's, Mass General, and Cedars-Sinai. And of course, our presenting physicians and researchers who are really donating their time and expertise for the benefit of us all. On a personal note, I want to share that a few years ago, I was diagnosed with multiple sclerosis, and it was a scary time. It was a time I remember feeling, quite frankly, pretty overwhelmed and kind of fragile. And it was not long after that a friend sent me this link to this, what we then called the educational update. And so I tuned in, and I was so impressed by the quality of the presentations, the generous nature of the doctors and researchers sharing their insights and best practices with what was working with their patients, lifestyle tips to enhance quality of life, different research that was in the pipeline. It was really full of hope. And I really feel like this event for me was a spark that kind of helped me shift from a place of uncertainty to more of a place of empowerment. And I felt like it was a great opportunity for connection and to really focus on learning as much as I could to really embrace the opportunity to shape my own healing journey. So I would hope that for today, for those tuning in virtually or in person, this event hopefully can be a spark for you to learn some new insights, hopefully meet some nice people, have some new connections, hopefully some nuggets that can help you in your own journey. If you maybe recently been diagnosed with a health challenge or are helping take care of a loved one or friend, or perhaps you're doing research to help find some treatments or other symptom management tools. So thanks for being here. It really takes a community. Really appreciate you showing up. I think it was the philosopher David Hume who shared that it's really when we start working together that the real healing takes place. So thanks again. So a few housekeeping items. I'll make this real short before I can pass it over to the main attraction. If you're here in person and you'd like to ask a question, we want to prioritize that opportunity. So feel free to raise your hand, and our nice volunteers will walk around with the mics and give you an opportunity to ask the questions. Or if you'd like to ask a question anonymously, feel free to write it down on one of the cards on your tables, and you can put that in the basket. And intermittently throughout the session, we're going to have volunteers bring those up to the presenters. If you're tuning in online, we would love you to also have the opportunity to ask questions. So please use the Q&A chat room, and please reserve that opportunity just for the questions for the presenters, and then we'll bring those up to the team as well. So without further ado, I'm going to pass the mic over to our first moderator of the multiple sclerosis session, Dr. Eric Clowder from Massachusetts General Hospital. Thanks again.
Thanks, Janet. It's a real pleasure to be with all of you here today, and it's great to see so many of you in person, and we're also really delighted to have those of you that are joining online virtually, and those that will eventually watch this neurologic symposium after the live recorded session here today. So I am one of the MS neurologists at the Massachusetts General Hospital. I have been a partner with the McCourt Foundation now for over a decade, and it's been a really valuable interaction that we've had. I have also had the opportunity to participate in this neurologic symposium a number of times, and it's really a highlight for me. Both to learn from the various speakers, and then also to have some challenging questions posed from the audience each year. One of the I think exciting things that I found when I was first thinking about, as a sort of budding neurologist, what area of neurology was I would I like to specialize in, and sort of be really involved with on a clinical and research side. Was I think one of the things that attracted me to multiple sclerosis was just the speed of advances, and I've seen that really come to life in my career. And I think this event is one of those opportunities to sort of reflect back on what is new in the field, but also where we're going. And so I think that's particularly exciting. And just in participating in this event also just makes it really clear just how quickly we make advances in the area of MS and other neurologic diseases, just related to how much has changed just since we held this event last year. So I'm looking forward to our time here together. So this year the weather's a little bit nicer than last year, and so it's nice to see more of you here in person. But I think the downside is that daylight savings time. So if you think that 10 o'clock came early for all of you here, it came a number of hours earlier for our first speaker, who's joining us from the West Coast. So we're really pleased to have Dr. Nancy Sykott join us from Los Angeles. She is the chair of the neurology department at Cedars-Sinai and is the Women's Guild Distinguished Professor in Neurology, and is the director of their MS and neuroimmunology program. She is going to talk to us this morning about biomarkers in multiple sclerosis. Nancy and I have enjoyed a collaborative relationship really over the last 15 years. She interviewed me for a National MS Society fellowship when I was just that budding neurologist that was getting interested in MS. So I will turn things over to Dr. Sykott, who will provide us with the first talk this morning. Just a quick bit about format. We'll have two talks. Please save your questions or write them down for the Q&A session, which will follow our two talks. So I'll turn things over to Dr. Sykott.
Can you hear me okay? I see you've walked away from the podium. So assuming that I don't hear from our AV folks, I just want to say thank you for that introduction. And I'm very excited to be joining you, albeit at a very early hour on a challenging weekend. I also want to thank the McCourt Foundation for the opportunity to share some updates. And I think hearing our introductions discussion about living with a diagnosis of MS, I think information is key and community is really important. So I think events like this are really wonderful opportunities for us to share information, but also to hear what's on your minds. And that helps guide us in what we're working on, how we communicate, and how we can make this journey as easy as possible for those of you who are living with MS. So I'm going to give you a very brief update this morning to talk a little bit about some of the work that we're doing at Cedars-Sinai, but also that's happening in the field at large in regards to what we call biomarkers. So biomarkers are incredibly important for neurologic diseases. They allow us to identify the disease sometimes before symptoms appear, but also allow us to make the right diagnosis and then to assess therapies and whether or not they're working. Also, prognosis. They give us an opportunity to perhaps have a better sense of which patients will need intensive therapy and maybe those who may not need therapy or could be monitored. So I'm going to give you a quick overview of this rapidly changing area. So first and foremost, whenever we talk about almost anything in neurology, but certainly multiple sclerosis, we have to first start with Jean Charcot. Charcot was the first to describe multiple sclerosis, and he did this by close observation of patients. But then, because he had no other tools available, he waited until postmortem and was able to look at tissue, brain tissue, in order to identify this disease that we now call multiple sclerosis. And his pathological descriptions have stood the test of time, but I think give us a sense of how difficult it was before the modern era to really be able to diagnose or assess someone in life who had a mysterious relapsing neurologic condition. But thankfully, with technology, we now have the ability to look inside the brain and to use MRI, magnetic resonance imaging, that gives us very detailed and beautiful images of the human brain. And this is important for many neurological diseases, but I think for MS, we see this as one of the keys. We've learned a tremendous amount about MS because of our ability to image during life and over the course of the disease. And it has allowed us to make a diagnosis sooner, not having to wait for clinical symptoms, but we can use the MRI to establish what we are the two canonical features of multiple sclerosis, which is what we call dissemination in space, meaning that there are lesions occurring in different parts of the nervous system. And here you see 3 of the areas that have been identified as part of the so-called McDonald criteria, which is the juxtacortical on the far left. In the middle, you see what's called I'm sorry, this was an infratentorial, then in the middle is a juxtacortical, and then a periventricular lesion here. So there are 4 different areas that are identified. The 4th one is the spinal cord. And if you have lesions in 2 of these places, then you've satisfied what we call dissemination in space. If you have an active lesion, here you see this gadolinium enhancing lesion. It's only one of the lesions in the brain that are taking up the contrast. This is a sign of acute inflammation, and this helps us to satisfy what's known as dissemination in time. So now we can use imaging to make a diagnosis of MS for both the dissemination in space and time. So this has been very, very important in allowing us to make a better diagnosis, but also to assess therapies. And as Dr. Klauder alluded to, first, I think I was probably 12 when I interviewed him for his fellowship. Just kidding. He came on the scene just as we were really starting to have multiple medications available for MS. When I started my career back in the early 90s, we had nothing to treat multiple sclerosis. And you can see the rapid and exponential growth in the treatments that are now available for disease modification in multiple sclerosis. And I would say that the reason that we've been able to have such a quick and accelerating number of therapeutics is due in part to having access to MRI to assess whether these therapies have benefits on the MRI biomarkers of inflammation. But what has happened, the pendulum has swung a little bit in that now that we have MRI that can show us these lesions, we sometimes find that patients come to us in the MS clinic who've been diagnosed with MS based on their MRI and maybe some vague symptoms. And it turns out that in studies that have been done, including work that we've done, Marwa Casey in our program at Cedars, found that up to 18% of patients who came to the clinic with a diagnosis of MS actually did not have MS. And in some cases, they were on therapy. Over half of them were being treated with disease-modifying therapies, but they actually didn't have MS. They had other things like migraine or lupus or one of the mimics of MS, of which there are many. And we think that's in part because these MRI lesions that you're seeing here on a very old-fashioned, what we call proton density scan, are not specific necessarily when you just see white spots on the brain. So how could we maybe make this MRI more specific? Well, it turns out our old friend Charcot made some seminal discoveries and descriptions of what these demyelinating lesions look like. And the key was that they were around blood vessels, very small blood vessels called venules. And this is where blood flow is quite slow, and inflammatory cells can then adhere to the endothelial lining, migrate out into the brain, and cause a lesion, an inflammatory lesion of what we would call multiple sclerosis. And they form what's also known as Dawson's fingers. So a very particular look that these lesions have on MRI and have a pathological specificity. So could we use this information perhaps to do a better job of diagnosing MS? Well, a very talented MR physicist, Pascal Satie, who joined our program 3 years ago, has developed a very exciting technique that we call Flare Star. And this is using the MRI scanner to detect that small blood vessel, which has blood in it. This is a sensitized scan for blood, and because blood has a magnetic signal to it. And you can see here on the far right panel that these lesions have a dot in the middle. And you can see that on all the different orientations, sagittal, axial, and coronal. And you see that there is a blood vessel, this dark line running through these lesions. And it turns out that these are very, very specific for demyelination. So, and many studies have looked at people who have MS versus those people who were thought to have MS but didn't, and they turn out to not have central veins if it's not demyelinating. Here's another image showing you the exquisite detail that we can see at ultra high field. These are 7 Tesla images, and you can see even more detail of how the vein goes through these areas that are bright on FLAIR, which are inflammatory lesions that we see in multiple sclerosis. So we're very excited about a study that we're doing that's called the CAVS MS study, along with Dan Antoneda at the Cleveland Clinic. This is a study that we are co-PIs on to validate this central vein sign. We have just finished enrolling 420 patients that we'll be following for 2 years. These are at 11 different sites that you can see here. And this was organized through an organization called NAMES, or the North American Imaging and MS Consortium, or Cooperative. And we're working together using new MRI techniques to do a better job of diagnosing and prognosticating for MS. So we have some of our initial results that we're looking at, which are quite exciting. And I do think will change the way that we diagnose MS, and hopefully will allow us to make an earlier diagnosis that we feel very confident about, and then provide the appropriate therapy for people. Another area of great interest is that we know that people who live with MS, when they've lived for a long time with MS, or some people who just have aggressive disease, that even though some of their MRI lesions may not look as though they're changing, they are getting more disability. And we think that part of this could be due to something called smoldering inflammation in the brain. And our treatments currently, unfortunately, don't seem to target this inflammation inside the brain as well as it does changing immune activation in the periphery or in the bloodstream. And one of the hallmarks of these interesting lesions that have been identified and may be very important in this understanding of progressive symptoms in MS are called paramagnetic rim lesions. So these are lesions you're seeing here, the pathology that shows a core of demyelination. So there's no myelin in the middle. And on the edges, we see signs of immune activation. And that includes what we see here. These CD68 cells are microglia or macrophages. And these are the inflammatory cells in the brain that are cleaning up and also causing inflammation right on the edge of these lesions. And we can see that these microglia have iron in them. They have, which is a byproduct of degeneration. So it turns out that you can use imaging to see these lesions. And these are the so-called paramagnetic rim lesions. Because there's iron breakdown products, you can see those with the magnet, with the MRI scanner. It's very sensitive to these iron-laden macrophages. And so we see these rims here, and we're able to now identify this somewhat unique set of lesions. So what have we learned so far? This is still a very new area and developing area, but we do know that these pearls could be informative for helping us with MS diagnosis. So having both a central vein and a pearl lesion may be even more specific for MS. But what I think is more interesting and potentially important is that they do seem to be associated with disease severity, meaning cognitive dysfunction and physical disability. They're also correlated with other imaging measures of what we call neurodegeneration, which would be loss of brain tissue or brain atrophy, and so-called T1 black holes, which are lesions that have a low signal in the middle, indicating that there's been significant tissue destruction. So we think these lesions potentially in the future could be helpful for us in understanding MS prognosis as well as diagnosis. And then, of course, we're very interested in using this as a biomarker for potential new therapies that might be targeting this very specific kind of inflammation that seems to be smoldering in the brain and the spinal cord. So my last topic, as I rocket through all of these new biomarkers, has to do with the way that we can use the blood to have better ways of understanding if disease activity is happening or if there's destruction going on within the central nervous system. And one of these markers is called neurofilament light chain. This has come the furthest in terms of the blood biomarkers that we're looking at for not only MS, but for other neurodegenerative disorders. And it's based on the idea that myelinated axons, so the nerve cells have the axons, which are the communications between the cell body and where they synapse. These axons are made up of these filaments, and there are different kinds of subunits of these filaments. But what we are talking about here is this neurofilament light. Now, this light chain neurofilament seems to be associated with disease activity in MS. And I'll show you some data that the levels seem to decrease after when you're on an effective therapy. But I do want to add a red flag to that, which is that these levels can fluctuate with other situations like age or other neurodegenerative disorders. So here's some data showing some of the things that we've learned about using neurofilament light chains. You can see on this top left-hand corner that there is a tight correlation between the serum and the spinal fluid. So this makes it really nice that we can just do a simple blood test and get levels that are correlating with what's happening in the spinal fluid and theoretically in the brain and spinal cord. We've also seen that the neurofilament light, if you look on the right upper chart there, you can see that with increasing T2 lesion load, that you see higher levels of neurofilament light. And also down below here, the gadolinium enhancing lesions, the more of them that you have, the higher the neurofilament light in the blood. And then if you have both brain and spinal cord lesions, then we see also that neurofilament light is even higher than if you had one or the other. So it does seem to be reflecting what's going on in the brain and spinal cord and disease activity. What's also, oh, there's my red flag. So it increases with age and other neurodegenerative disorders and brain injury. So we have to take it with a grain of salt. But what's also, I think, very exciting is that we have some very preliminary data that putting patients on a highly effective therapy will result in a drop in those neurofilament light chain levels. So potentially would allow us to have a biomarker other than having to do these imaging scans, and perhaps even more sensitive than some of the imaging that we do, that would tell us that the therapy that we're using is helpful. On the other end, it may help us when we take people off of medication. When they get to be older, we frequently will take individuals off their medications, but we don't know for sure if they're still having disease activity. And this could be a way to monitor that as well. So still lots and lots of work to be done. But I think this is one of the promising serum biomarkers, of which there are many that are being looked at, just to give you a sense of where we're heading in the field. The other area that seems to be important for this neurofilament light is that it's associated with disability. As you can see here, this is the EDSS scale, which is the measure of disability. And you can see that those who had the highest levels of neurofilament light were more likely to develop this more significant disease. So I want to just end there and say thank you for the opportunity to give you this very fast update. I'm looking forward to our question and answer time, and I look forward to hearing the rest of the presentations today. So thank you again for your attention, and I look forward to joining you again soon.
Thank you, Nancy. That was a great overview of, I think, 3 areas that are really exciting and I think are ways in which research is really translating into clinical practice. Our next speaker today is Dr. Lori Cox. Dr. Cox is an assistant professor at Harvard Medical School and is an investigator at the Ann Romney Center for Neurologic Diseases. She will be speaking to us today on the link between the gut and the immune system and neurologic disease. So I will turn things over to Dr. Cox.
All right. Thank you so much for the introduction. And I also want to thank the McCourt Foundation for really everything that they're doing to raise awareness, to educate patients, and also to support some of the research that we do. So today I'll talk to you about the gut microbiota in multiple sclerosis, some of the things that we know, and some of the things that we hope to do with our research in the field. So first off, what is the gut microbiota? So it's about 100 trillion organisms living in you. So go ahead and pat yourself on the back. You are supporting a community of 100 trillion. So good job there. And we really want to think about microbes as providing a lot of beneficial functions to us. So they help us aid in digestion. They can produce vitamins. They can shape the immune system. They protect us from infections. They regulate our metabolism. And they can even shape brain development. Now, there's a lot of things that change our microbiome as well. We know that antibiotics can change our microbiome. Lifestyle, like exercise, can change your microbiome. Diet can be a big shaping factor as well. And then finally, hygiene can affect which microbes are actually in your gut. Now, we also know there's a bidirectional interaction with inflammation and other chronic diseases that can change your microbiome as well, and that can feed back into the disease. So how do microbes in the gut actually affect the brain? So this is a complicated schematic, but I really love how it illustrates all these different pathways. We know that microbes can make compounds that trigger cells in our gut to make neurotransmitters. But what's even more exciting than that is microbes can make every single neurotransmitter we know about. And this is starting to come to be very important in things like depression and anxiety. Now, we know that microbes can also change immune cells in the gut and have those immune cells traffic into the brain and into the CNS. And that's what we really want to understand so that we can try to find microbe-based treatments for MS. Microbes can also signal through the nerves in your gut, and that can affect pain responses. But this is a two-way street. If you've ever been really nervous or anxious and all of a sudden you feel your stomach feels a little funny, or if you've ever had those butterflies in your stomach, that's because you're secreting neurotransmitters It's changing gut motility, and you're changing your gut microbiota. So our center became very interested in trying to understand, is the microbiome different in MS subjects? And we published one of the very first papers in this area. And we found that a couple of microbes were Methanobrevibacter and Akkermansia, and that butyrate-producing microbes were down. And now there's probably about 20, 25 papers in this area. And one of the most consistent findings is that butyrate-producing microbes are down in MS. And we know that this compound made from microbes can increase T regulatory cells, which can sort of put out the fire. Now, we also saw Akkermansia was up. Again, one of the most consistent findings found around the world. We used to think it was a bad bug, but I'm going to show you evidence today. We actually think that its rising levels are actually helpful in MS. We did another study in not just in relapsing remitting patients, but also in progressive MS. We found many similar changes. And again, once again, we found elevated Akkermansia. But we tried to use clinical data to understand its role even better. And we looked at EDSS and found there was a negative correlation. But what that means is the patients with the highest levels of Akkermansia were in fact doing the best. We also used a questionnaire to assess quality of life. We know that fatigue and depression can sometimes be higher burdens in MS patients, and we were able to identify microbes associated with anxiety and fatigue in MS. And what's known is, again, microbes can affect your mood. And so can we actually start to develop new probiotics to improve quality of life in our MS patients? We've looked at microbes and how they relate to imaging parameters like T2 lesions and brain volume. And once again, we're finding these beneficial associations with Akkermansia. The more Akkermansia the people had, the larger their deep gray brain matter was, and the lower the lesion size was. And so this was very curious. It's up. Is it good? Is it bad? One thing I just want to share with you as a microbiologist is that different strains of bacteria can have very different effects. And just to illustrate this, I'm going to tell you that all of these critters up here are the same species. They're all Canis lupus, but we can understand that wolves have a very different role in their ecosystem than maybe your adorable pets at home. We know there's 4 different types of Akkermansia, and they have very different functions. And in fact, even some of the Akkermansias can make vitamin B12. So to investigate this a little bit further, we went to our MS patients, we grew Akkermansia, we found an entirely new type, and then we gave it to an animal model of MS to test how it happened. Now, the higher the lines are, or the more severe the disease is. What we found is when we gave this blue one, this H3 strain, it really helped the animals recover faster, and we identified specific immune pathways by which this was happening. And so the lessons that we're really learning here is just because a bacteria's increase doesn't mean it's bad, and that we think this model of using clinical measurements can help us identify useful relationships. We think Akkermansia is actually responding to changes in MS, and we've actually identified that this is coming from microRNAs produced in the gut, and we're moving forward with trying to develop these microRNAs into therapy. Now, there's a lot of new frontiers of microbiome immunologic communication, and there's many microbes that can have specific effects. And we're really launching new initiatives to see how the microbiome can affect monocytes and microglia in the brain. And we just saw some beautiful images about how that could be very important in the clinical management. We also know that B cells have a very important role, as shown by the efficacy of our anti-CD20 therapies. We know that there are good B cells and bad B cells, and so now we're trying to understand how the microbiome affects those cells, subsets as well. When it comes to disease-modifying therapy, there can also be important bidirectional interactions with your gut microbiome. So first off, the disease-modifying therapy might shift the gut microbiota. It might be a substrate or have antimicrobial properties. But secondly, and this could be very important in clinical management, the microbiome sometimes can inactivate treatments or activate, or they can modify the DMT toxicity or affect the clearance. And so this is also another area in clinical research where we should be thinking about what's going on in your gut. Now, we know there's also a lot of interaction with the microbiome and host lifestyle factors. And one of the areas that people are very interested in is, can we understand how we can change our diet to change the gut microbiota to improve outcomes? So there's some really beautiful studies run by Laura Picchio showing that intermittent fasting might have improvements in MS, and that might actually have an effect on the gut microbiome. The same group has also done a multi-omic study where they found that people who have higher intake of red meat and higher inflammatory cells, and this was linked to specific metabolites made by the gut microbiota. Another fascinating interaction is microbes can change your hormones. So we know that hormonal changes can shift the microbiome, but your microbiome can also affect how much hormones are in your blood by this enterohepatic circulation. We know that there is a quiescence or a protection from disease during pregnancy, and the pregnancy hormones can shift the gut microbiota, and some of the protective effects may be regulated by the change in the gut bugs. And so finally, we're thinking forward towards therapy. How can we modulate the gut microbiome in MS? People have considered antibiotics, but the data isn't there. It's not helpful to treat MS. There are probiotics. There are current on the market probiotics that seem to have a beneficial effect. I'll share a study with you there. But we think we need to design new therapies for MS. We can think about fecal microbiota transplants, but it's much less controlled. And there are definitely some off-target effects and some safety concerns there. We're now pioneering microbial targeting microRNAs. And then you can also think about using diet or metabolites. So in our center, we did a trial with probiotic therapy with these 8 microbes, mostly bifidobacterium, lactobacillus, and strep. These are things you can find at your pharmacy, just on the shelf. We gave probiotics for 2 months, and then we stopped it and then looked at the microbiome 3 months after we stopped probiotics. When the patients were on this probiotic therapy, lactobacillus went from 1% to 30%. We were taking over that gut microbiome and we had big changes. But when we took them off the probiotics, the lactobacillus went away. But what was surprising is we looked at their immune system and we found that the probiotics were increasing these anti-inflammatory markers, decreasing inflammatory markers, and the changes in the immune system lasted even after they were off the probiotics. And so I think that really suggests that you can have a short-term intervention with lasting changes in the immune system. There are new probiotic trials happening with, again, what's established off the shelf, but we're really trying to find disease-specific microbes that we think could have a beneficial effect. We also think that there could be a beneficial effect by using oral microRNAs. These are easy to manufacture and can also help boost the good gut bugs in our gut. And finally, again, we've thought about doing fecal microbiota transplants, but because of some safety concerns, we've really taken a step back from that. So I think the future perspectives in this area is that new microbiome-based treatments are emerging, and that makes me very optimistic. But we need this process to really identify which patients need this intervention, and really thinking about diagnostics and biomarkers, as we just heard, is incredibly important. We think new treatments should be paired with the biomarkers to have better clinical control. And we should think about the level of microbiome intervention based on the disease status. So can we find something to prevent MS? Should we have different treatments for onset's attack, for maintaining remission, and finally, treating progression in MS. And so we're really excited about where this field is going towards, and hopefully we'll have something that we can really bring into the clinic soon. So with that, I'd like to acknowledge the many, many people at our center involved in this work, and just thank the McCourt Foundation for everything, again, they're doing to educate patients, highlight the research, and to support the research we're doing. Thank you.
Yeah, no, I think that's a great point, because we know that people are not excited about having lumbar punctures done and repeatedly, and that doesn't really move the field along in terms of ease of collecting this information. So the ability to use these assays that, as you said, are ultra sensitive that they can detect small amounts of material that is appearing in the blood, but reflecting what's happening in the central nervous system is very powerful. And neurofilament light is just one of those biomarkers. And as we're hearing, there's also a lot of this kind of technology, mass spectroscopy and other approaches that will allow us to look at very, very small amounts of and potentially informative chemicals and other things that are in the bloodstream that will help us. So that's another technological advance. And I had forgotten that your project was on neurofilament. That's ironic.
Thank you, Lori. That was a great talk on a pretty complex topic, but one that I know that as clinicians we're interested in, this link between diet and how that might modify the disease course of MS. But also I know a topic that is important to our patients as well. And one example of that is just the questions that came in before the meeting. Probably the most common question was related to diet and how do we, what do we know about diet and what's the latest recommendations and what's the scientific basis for those recommendations. So we'll take questions now for the remainder of the session this morning. I'll start us out with one of those questions that came in early, as those of you can sort of flag the mic and ask questions live as well. So I had mentioned a lot of the questions relate to diet, and I think Dr. Cox's talk certainly hit on that, and I think we can expand on some of those concepts here. I had a question first, though, that I might just ask. So and maybe this is a theme that sort of like spans both of the talks. Is some of the challenges with research and just methods. So maybe as we have Dr. Sykott come back on, I'll pose the first one to Dr. Cox. So it seems like with the microbiome, there's a lot of data that you sort of are trying to sort of collate and make sense of. Can you talk just a little bit about how is that done when you have all of these different bacteria and you're trying to measure levels and individual, patients? Tell me just a little bit about that and maybe just how that has changed over, a period of time and how technology relates to that.
Yeah, absolutely. So one of the most exciting things in this area is the fact that sequencing technology has really dropped in price. So it's not a problem for us to sequence 1,000 samples, to look in your guts, to look in the gut microbiome. But the most important thing for us is really getting into the clinic and seeing how patients change over time. And that's really the area that we're trying to focus on. And using these new imaging tools, as we saw in the earlier talk, we want to see, can our microbes linked to changes in the brain over time, and really use that to find very sensitive relationships and say, if this microbe is going up, are these patients doing better or doing worse? There's a new area of technologic development that we'd love to see more advancements in and the price drop a little bit more, which is metabolomics. And so the other area that we're getting into is asking, what chemicals do the microbes make in the gut, and how can we use those for new treatment? I really think about it as the new Amazon rainforest of pharmacological compounds. I think there's some really interesting things there. But metabolomics is not as far as DNA sequencing. So I think that's a second area of big data that we're getting into, and I think it's very promising.
Great. And Nancy, maybe, kind of along those same lines, maybe you could kind of speak a little bit to sort of how we take some of these interesting findings on imaging and blood biomarkers, and how do we move those from the research sphere into the clinical sphere so that we could use them in real time in practice?
Yeah, so thanks for that question. That's something we're very, very interested in. Having been in this area and done lots of imaging research, we see these wonderful findings that we do on our research studies, but how does that translate into the clinic and allow us to make a difference and actually apply what we've learned? So we're very cognizant of this, especially as we're looking at some of these imaging biomarkers, that they really need to be easy to use and they have to be translatable. And at the end of the day, it's the neuroradiologists that really have to embrace these tools. And we have to recognize the real world situation, which is if we have very complex post-processing that has to happen, meaning that you have to put it onto another computer and run a lot of extra software, that's not really compatible with the realities of looking at imaging and having to go through many scans per day. So we're actually looking at using something that everyone's been hearing about, which is artificial intelligence, to take these images. And the imaging is actually a field that really lends itself well to this technology. So you can feed in these images that have been expertly assessed, and the algorithms can learn from that information and then learn to identify things like the central vein. When you have many lesions, it's very time consuming. I can tell you that we're doing this for our study, and manually going through and identifying the lesions is definitely something that's not scalable. But we're thinking about this from the very beginning, and I give a lot of credit to Pascal Satie, who's really been thinking about this and working on this. And the technology that you need in order to do that is actually supercomputers. So this is a huge amount of data that has to be generated and then has to be chunked through, has to be processed in order to come out with this algorithm to do the automated lesion detection, for example. So I think that's a huge advance, and it's coming into play for all of these very large data sets that will be very, I think, informative. So we could take the blood biomarkers, we could take the imaging biomarkers and combine them, and then really maybe have new insights. We could take the microbiome from our last speaker, just fascinating work, and put all of that together and learn something that we don't know already because we're not able to make all of those connections. So I think this is an area of great promise and excitement moving forward.
One of the observations from your talk on the neurofilament light, it just sort of tying back to when I was originally introducing you, that proposal to the National MS Society, one of the things I was interested in neurofilament light. At the time, this proposal I was making was to look at this biomarker in the spinal fluid and then relating that to imaging findings. But one of the key things that really advanced that use was being able to detect it in the blood and to have an ultra sensitive way of detecting this measure in the blood. So I don't know, Nancy, if you can comment on that as well, and how that's helped sort of advance this.
Yeah, no, I think that's a great point, because we know that people are not excited about having lumbar punctures done repeatedly, and that doesn't really move the field along in terms of ease of collecting this information. So the ability to use these assays that, as you said, are ultra sensitive, that they can detect small amounts of material that is appearing in the blood, but reflecting what's happening in the central nervous system is very powerful. And neurofilament light is just one of those biomarkers. And as we're hearing, there's also a lot of this kind of technology, mass spectroscopy and other approaches that will allow us to look at very, very small amounts of and potentially informative chemicals and other things that are in the bloodstream that will help us. So that's another technological advance. And I had forgotten that your project was on neurofilament. That's ironic.
So yeah, and I'll say that, the technology, just like those ideas, like come to fruition in different ways that you can comprehend, just related to advances that are made in other areas of medicine, which I think is an exciting aspect of what we do. Nancy, maybe I'll come back to, I know there was a question came in early just related to what can mimic MS and the diagnostic aspect and how we use imaging. You sort of made a comment related to the percentage of patients that we will see sometimes in clinic that come to us with at least a questionable diagnosis of MS, and then we're as clinician tasked with trying to determine, okay, well, was that diagnosis correct? And if it's not correct, how do we proceed moving forward? And I know you mentioned some of the work that you've done, just characterizing how common this is. And maybe you could comment just a little bit on sort of like, what is your approach when you encounter that situation where either you're seeing the patient initially for the first time and you're trying to figure out, diagnostically, is this MS or not MS, but also someone that you've seen where maybe they're seeing you as a second opinion about MS, and they've already been diagnosed with MS and sometimes on treatment.
Yeah, so I think this is something that we deal with each and every day in the clinic, and is very important. What we see in this era, because it's so common that people can have access to imaging and have MR scanning done, that very frequently people come to us because they have changes on their MRI, what we sometimes refer to as non-specific white matter changes. And along with that, we sometimes see that people have some non-specific symptoms. So as all of us know who treat MS, there's the McDonald criteria that identifies the classic presentations that people who have MS present with. And that includes having, for example, optic neuritis or brainstem syndrome, or having a spinal cord, what we call a myelopathy. So very often what happens when people are coming to us with, they have some vague symptoms like some tingling or non-specific kind of symptoms, and they do have changes on their MRI. And I think what we've seen for those of us who see a lot of these patients, the radiologist will give a long list of things that could potentially be causing those white matter changes. And one of them includes multiple sclerosis. And for non-specialist general neurologists who don't have the time or the expertise to look at the scans directly, we'll see this and then we'll make a diagnosis. So things that we can do to help make this more specific include really applying those McDonald criteria, which is, there has to be a clinical syndrome that is consistent with what we typically see in someone who has a first attack of multiple sclerosis. And then the second would be the imaging findings. So as I showed, there are very specific locations, and hopefully one day we'll have the central vein information that will help us to better differentiate those non-specific lesions which do not have central veins versus those that do. And then the other thing that's very helpful, two other things, we do visual testing. So looking at OCT and looking for subacute changes in the eye that are associated with an optic neuritis. And then finally, spinal fluid sampling, which I find to be very, very helpful in identifying some of these patients who maybe have vague symptoms or they have some changes in their scan and you're not really sure. I feel much more comfortable watching patients if their spinal fluid does not show evidence of what we call oligoclonal bands or immune activation. So I find that a really helpful differentiator. And then just two other things I would say, we have a long list of what we call mimics, and those include things like migraine would probably be one of the most common. The other are things like lupus or vasculitis that can give lesions that look unusual like that. one of the things that we're really excited about this study that we're doing, the CAB study, is we're enrolling patients that have both classic presentations, so typical kinds of presentations for MS, and atypical. And we're really, I'm really excited to look at that group because that's more like real world, right? Where you get somebody who comes in and they have these funny symptoms and maybe they had a headache and you're not really sure. And then you look at their scan and they have some lesions that maybe those are demyelinating. We're going to follow those folks for 2 years and we're going to really see if we can, make a better diagnosis and actually tell them that they have something else, right? Because that's the main thing, that we don't want to be treating people for MS when first of all, they don't have MS, but they may have something else that has another treatment. So thanks for that question. It's a very complex area.
Great. So maybe we'll switch gears back to diet and the microbiome and that interaction. Lori, maybe you could go into a little more depth on kind of some of the various diets that have been proposed, and why, maybe just provide some rationale about, is there basis for using various types of diet in treating MS or other neurologic disease?
Okay, yeah, fantastic. And I think it's really helpful to consider how are these things working, and that can inform the way we live our lives. So one is the intermittent fasting diet, which seems to help attacks. And one of the things that happens with intermittent fasting is the gut has a time where there's not a lot of food in it. And this bacteria I told you about earlier today, Akkermansia mucinifila, the second name of it means mucus lover. I know that not too many people are eating, so it's okay to talk about the guts. What it can do is it can actually get all of its food from us, can use the mucus in the gut as its carbon and nitrogen energy source. We know that in times of fasting, Akkermansia actually goes up. So it'd be very interesting to see if that is in fact a connection. The second area of diet is thinking about fiber and fiber sources. So fiber is food for your microbes. So up in the upper GI tract, you take out all the simple carbs, the starches, the sugars, but down in the lower gut where your gut makes butyrate and propionate for you, your microbes need the fiber. And so definitely certain types of fiber can be very helpful. I will say if you're introducing fiber to your diet, do it slowly. If you go from no fiber to a lot, you're going to be uncomfortable because your microbes will kind of have a party with it. So again, bring it in gradually. An area that hasn't been studied yet, but could be very interesting. I told you about butyrate before, but propionate is another molecule made by microbes, and people have shown administering propionate might reduce attacks or slow progression. And then completely outside of the MS field, people have found certain types of fiber promote butyrate and other types of fiber promote propionate. So what type of fiber? It's these resistant starches that you find in tapioca powder. So this tapioca powder might produce more propionate from your gut. Okay, and then so we talked about intermittent fasting, we talked about different types of fibers. And then finally, people have looked at the Mediterranean diet. And that's very interesting because it has polyphenols. These polyphenols can also be metabolized and shape the gut microbiota. So everybody has individualized responses. So one of the things that I just recommend is, take a journal of how you're feeling, try a different dietary change and see if it really helps you, because not everybody will respond in exactly the same way. But there's really a scientific basis to think about how these diets are really shifting the gut microbiome.
Yeah, great. And then I'll just, there's a question here from the audience. So we'll go to
do you recommend that patients introduce a probiotic to their diet every day in addition to any prescription or over-the-counter medications we take anyway?
So yes, again, I would say to make sure that it take a journal before and see if it is really helping you. Most studies using over-the-counter lactobacillus and bifidobacterium have had beneficial effects. There actually is a new company out making an Akkermansia probiotic. There's one bacteria I would tell people to avoid with MS, which can be found in over-the-counter probiotics. It's one of the lactobacillus. The species name is Reuteri, Reuteri. Now, this can be beneficial sometimes, but studies in mice show it actually increases inflammation. So that's just the one I would avoid. I would avoid Lactobacillus reuteri, but the rest of them in our patients, we saw other strains of Lactobacillus were beneficial. And other strains of bifidobacteria were beneficial. I'll just give a quick example of why probiotics might have differential effects. There's another bug called Lactobacillus GG. It really can like grip onto the gut, and this probiotic can help distract the immune system and help with milk allergy, which is fantastic. But that same action of gripping onto the gut is bad for people with Crohn's and colitis. So just because, we say, oh, take a probiotic, see how you feel with it. And most of the stuff that's over the counter could be beneficial.
Great. Yeah. And then we've got another question here live.
No, I'm going to try. Hi. I wanted to ask, as neurologists, when you first meet your patient with MS, you already know they have MS. Do you recommend cognitive therapy? We're off the subject of what we're talking about here with but just as a neurologist, that's one of my interests to make sure that because that's been one of my benefits of having a therapy group to attend. And also, do you recommend my God, I can't think of a nutritionist for MS patients?
Yeah, those are two great questions. So the and maybe I'll answer part of that, and then also let Dr. Sykott weigh in. So to the first question, when you first meet a patient with a known diagnosis of MS, do you recommend cognitive therapy? I think that what we try to do is when we're meeting a patient for the first time, we're trying to in some ways probe what domains or what areas most affect quality of life for that patient. And in that sort of initial screen of what symptoms are most troublesome, we're certainly asking about memory, about other cognitive domains like attention, kind of information processing. Sometimes that comes out in that initial appointment, that is an area of difficulty. Sometimes we'll do screening using a cognitive test that we can in the clinic to try to determine, if there's some dysfunction with areas of cognition. And through that initial assessment, if we do determine that there are some cognitive issues at play, many times what we do is then obtain a more comprehensive battery of cognitive tests. And so that could be seeing a neuropsychologist and spending a couple hours really doing cognitive testing so that we can generate a full report that can be useful in different ways. Sometimes the neuropsychologist will say, well, we recommend these various tips that are really practical and real world that can help patients. Other times they'll say, well, we feel like this patient may benefit from more regular and comprehensive cognitive therapy, where you may meet with a speech therapist and really work on promoting various cognitive abilities. Other times that battery of cognitive tests can be useful in serving as a baseline, kind of where does someone perform right now? And then we can use that perhaps in the future if it's noticed that, some cognitive abilities subjectively get worse over time. Then we could repeat that testing, say like after a year or several years, and go back and make that comparison. And maybe I'll let Dr. Sykott also comment on cognition. I know that's an area of interest of yours, both clinically and on the research side.
Yeah, so thank you for that. I agree with everything that you've said in terms of how we would approach initially a patient who comes into the clinic, just seeing where all the strengths and weaknesses are. One area that I would also add, as we commonly find that people who live with MS have mood issues, in particular depression is very common. And depression can actually impact cognition in a very powerful way that sometimes even clinicians are not aware of. So one of the things that I would definitely include would be assessing for mood and also treating for mood disorders, because sometimes we find that the cognitive issues will improve when mood improves. And that's the easiest way to get a benefit, since we know that cognitive therapy can be helpful, but doesn't necessarily, in terms of finding adaptive strategies, but doesn't change the underlying situation, which could be related to disease burden. But if it's a mood-related issue, that can be more amenable to therapy. The other question I think was about nutritional therapy. And so I sort of make a comment about, I grew up on the East Coast and then I came to the West Coast to practice. And it used to be that the first question patients would ask is, will I be in a wheelchair once they're diagnosed with MS, which thankfully we can say is very unlikely these days. But the most common question I get now, and I don't know if it's a California thing, but maybe it's just a change in people's expectations, is what diet should I be on now that I've been diagnosed with MS? And I'm so glad to hear that we're making progress on this in this area. But I definitely recommend that people have a healthy lifestyle. And that can include addressing issues of diet and obesity and other comorbidities. So we saw a beautiful presentation at ACTRIMS this year about how comorbidities can complicate or increase disease disability in people who live with MS. So having a healthy lifestyle all around, managing hypertension, diabetes, obesity, can be very beneficial, not only for your heart and lungs, but also for living with MS. So for some folks, having a nutritional consult is very important in helping them meet those goals and have specific dietary recommendations. So definitely include that in our evaluation.
Yeah.
Thanks.
And just an observation is that that many of the day-to-day symptoms are interdependent or linked. And so many times we see that mood relates to fatigue and energy level, and that's also very influenced by sleep. So many of these things are sort of interrelated. And personally, I promote exercise with my patients, and we find that helps with energy level. It helps with mood. So there's a few different ways that we can tackle these symptoms aside from medications, which, as in general, we try to avoid adding a medication for every symptom if there's an easier natural way to be able to tackle a symptom. One, going back a little bit to the various types of diets, you'd mentioned, Lori, the intermittent fasting, and there was a nice study actually that was just presented at one of the American MS meetings in San Diego just a few weeks ago related to this. So kind of a preliminary study looking at this intervention and when we say intermittent fasting, it's probably useful to kind of talk about what does that mean? and sort of like how do you sort of employ, and so I know in this particular study, they limited calorie intake, I think 2 days per week, primarily with eating salads on those 2 days. I think limiting the calorie intake to about 500 calories per day. And what was interesting about this study was that in a relatively short period of time, they noticed improvements in clinical outcomes, but also when they did the immunology, what they found was that the various immune cells that are more regulatory tended to come to improve, and the inflammatory immune cells tended to go down, even within about 12 weeks of using this diet. And I know they haven't yet put in that piece of the microbiome with that study, but I don't know if you have any comments sort of on sort of where sort of these interventions sort of are and how they relate to the what you presented earlier.
So I do know that they're collecting gut microbes from that study. And in animal models, they've actually been able to show that the shifts in the gut microbiome can actually be protective. But outside of what's happening to the gut microbiome, I think, as you mentioned, there can be a very profound effect on the immune system. And some of the ways that I think about how diet and nutrients interact is that immune cells, when they're dividing, they're quite hungry, they need a lot of nutrients, and actually cutting out some of those calories, again, on a way that could be tolerable, 2 days a week, not to the point where, you would have adverse effects. It can stop that proliferation or big expansion of those pro-inflammatory immune cells. So that's one area. But the other area that we are starting to see a lot of promise from as well is with the Mediterranean diet. So that's a different approach that actually uses it's high fiber, it's high fat, but the right type of fat, more coming from olive oil or from fish. And high in polyphenols. And that could also be a different dietary approach because the same diet won't work, for each individual person.
Yeah. What I think is pretty encouraging is that these diets are now really being rigorously studied in multiple sclerosis and in a controlled way, or as much as you can sort of control diet studies. So I think it's encouraging that these studies are ongoing and that there's so much scientific basis that is incorporated into those studies. We have received a number of questions related to progressive MS, and this is an area of intense interest and really is still, from a therapeutic standpoint, an unmet need in the community. And the questions relate to what's promising in the area of therapies for progressive MS. I was going to maybe ask Nancy this question, just related to some of the biomarkers that that you shared. One of the things that you talked about were these immune cells called microglial cells that we see that can be activated in the brain and relate to inflammation, both in what we consider relapsing MS, but also in progressive MS. So I don't know if you can comment a little bit on how we can harness imaging to assess progressive MS treatments, and sort of how is that approach different than what we've traditionally done in approving therapies for relapsing MS?
Yeah, so thank you for that question about new approaches for addressing progressive MS, including biomarkers and how they might inform our treatment options. So as I showed in my presentation, we now are able to identify a subset of lesions that appear to have an active rim around the very outskirts of where the demyelination is taking place. And the cells in the brain that seem to be located there are these microglia. These are the resident immune cells in the brain that clean up after inflammation. They also are involved in other neurodegenerative disorders, as we were talking about. And so I think that we see them at these lesions, which pathologically are what we call chronic active lesions. So there's still some activation, there's still some immune activation going on there, even though when we would look at them on traditional imaging, they would not have contrast enhancement. So they're not opening the blood-brain barrier. So another way of thinking about it is this is compartmentalized inflammation that's happening inside the brain and the spinal cord, but we're not able to see it with the usual tools that we used for relapsing MS. And therefore, those tools that we use for relapsing MS were what we use as biomarkers for effective therapies. So it's probably not a surprise that the therapies that we have mainly are anti-inflammatory. So they stop those new lesions that have the activation with the gadolinium enhancement. But we are seeing now that our therapies are probably not targeting that kind of slow, smoldering inflammation that we see behind the blood-brain barrier or without the contrast enhancement. And the microglia seem to be playing a role there. So in order to target it, we first need to be able to monitor it. So I think that's where we're at right now with our imaging. So we can use the MR techniques that I showed. There's also another technique with PET, or positron emission tomography, that allows you to see those activated microglia. And so we saw a lot of that data presented at the most recent meeting. So it's very encouraging that we now have some biomarkers. Now we need some treatments that are really going to have an impact on those kinds of lesions. So there are some approaches, I think, now that we have a better sense of maybe what's happening there, that we could target therapies that get inside the beyond the blood-brain barrier. The therapies we have now, for the most part, don't do that. They work in the periphery. They affect immune activation so that fewer cells are migrating into the CNS. But we haven't found a whole class that could potentially stop the inflammation inside. So, we know that a class that's being tested are called BTK inhibitors, or Bruton's tyrosine kinase inhibitors. Some of them seem to be able to get into the brain and spinal cord, and there's great hope that they will be able to target these specific cells and specific lesions. I think the jury's still out on that, and we're going to need to see if that's the case. There's also ways to potentially attack the B cells, which we know are very important in MS disease activity, but there are B cells that are inside the central nervous system that might be driving some of this inflammation that we are not targeting currently. So that's another approach. And then we haven't talked about Epstein-Barr virus, but some of those B cells may be harboring the Epstein-Barr virus and replicating. So another approach that people are taking is try and kill off those specific B cells that might be driving that compartmentalized inflammation. So I think we really have a lot of work to do. I think another area we need to make progress on is in imaging of the spinal cord, because that's really, when people are living with progressive MS, it's mainly the walking issues that they're having. And we need better imaging of the spinal cord again in order to have those biomarkers to see if our therapies are having an impact. But I would say, as you alluded to, Eric, this is an area of intense interest and study. And I do think that we're going to have some things to offer our patients in the relatively near future. I know we've been saying this for a long time, but I do feel like we have better targets and lots of therapeutic approaches to try. So I'm hopeful.
Well, I know I'm optimistic that we're going to make progress in this area. And I always think about, as we understand the underlying biology, and we can sort of target that in certain subpopulations or subgroups of our clinical population that we treat, then that really sort of leads to these new therapies. And we found that it isn't particularly successful just to take a treatment that we found that has worked in relapsing remitting MS and then use it in progressive MS. So I think this sort of maybe it's not a new approach, but the approach of sort of saying, okay, well, what's different or what's happening differently in progressive MS, and then really trying to target that aspect, I think, is where we'll find success. There's been a few questions that have come in just related to sort of like, how do we as neurologists discuss new treatments with our patients in the clinic? And is that something that we, when patients do find something new, that they may read about or sort of hear about just in, their various communities, do we mind hearing about those specific questions in the clinic? And then sort of another question came in about how do we discuss with our patients about mood and depression, and sort of what's that approach? So maybe Nancy, I'll have you we've got about 5 minutes left, so maybe I'll let you answer quickly, and I'll add on to your answer.
Okay, I'll try and be quick. So 2 big topics. So I love the fact that MS patients are among the most informed patients that anyone interacts with, and very, very often will come in with things I haven't heard about yet. Some of them promising, many of them, unfortunately, not so. So I think our role as neurologists is to try and give guidance in terms of what we know and how we evaluate if therapies are effective or not, which is not anecdotal, which is these long-term research studies that have to be done. So it's sometimes frustrating, but I welcome it when I'm being challenged by patients to really express and explain why this might or might not be something that's worth trying, and definitely keeps us on our toes, and is great for our trainees to hear and interact with such informed and sophisticated patients. The other issue you talked about was depression. And, there's a list of things that we go through every time when we see patients, and depression and mood are definitely on that list. Because as you alluded to, they're all interrelated with fatigue and mood and cognition. And these are the so-called hidden symptoms of MS that are very, very common. They keep people from being able to work or have satisfying relationships and really to live their best life. So we really want to tackle them. And the good news is, as you alluded to, there are both medicinal and non-medicinal ways that we can address mood, in particular, as you said, exercise and therapy and medication. So very important and great questions. And I'm leaving you the last 3 minutes.
Yeah. I'll add to that. I really enjoy talking about sort of like new areas of research with my patients. So I really do encourage those types of questions. When they're to answer one sort of subpart of that question, when we do have a new treatment that is approved for MS, how do we approach that when patients are already on a treatment? I'll say that it kind of depends upon what the specifics are of that treatment. Is it very similar to what we already have for use in MS, or is it a totally different category of treatment that maybe works by a different mechanism? And for some patients, maybe there's already some evidence that their treatment isn't working as well as what we'd like. And those are probably, those are the patients maybe that were more apt to move to a newer treatment, as opposed to someone that's really responding well to their treatment. In that case, we may just decide to stay the course, even if something promising has just been approved by the FDA. And then I'll add just one thing. One of we recognize, I think, as a community, that mental health is really important, and how there is the link between MS and mental health. And at least at MGH, we've been fortunate to have a psychologist that's really interested in the area of mental health and wellness, and we've sort of taken that multidisciplinary approach to embed a clinic within the MS clinic, really targeting some of these aspects that may come up around the time of adjusting to a new diagnosis of MS. So that's a new development, and hopefully it's a model that we can show is effective at MGH so that it can be used in more clinics that care for people with MS. We have a question here from the audience. We'll take
something that hasn't been talked about yet. I know some MS patients are taking marijuana to help with pain and discomfort and maybe even psychological issues. I'm wondering how you feel about the use of marijuana for that.
Great. So certainly marijuana can be kind of like a controversial topic and sort of how we use it in practice. But for a number of years, I have certified patients to use marijuana because we have clearly seen the benefits for some of the areas that you mentioned, MS-related pain. And I would say the other symptom that marijuana tends to be very helpful with is muscle tightness and spasticity. And many times, we may use various treatment modalities for spasticity, and that could be things like stretching. That could be some of the medications, muscle relaxers. But medical marijuana is definitely something that helps with that, and so I encourage patients to explore that if they feel comfortable. At least in Massachusetts, there's been legalized marijuana for medicinal use for quite a number of years, and I think it can be sort of another area that we can use to target some of these really disabling symptoms for some patients, at least. So we have a couple. Actually, we're out of time, but I wanted to just, as we wrap up, maybe each of us can give sort of one area or one sort of topic that we're most excited about, whether that be in our own research or what we see in the community. And sort of we'll leave this as sort of like the optimistic sort of future area of research that maybe we'll be talking about at the symposium a year from now or 2 years from now. So Lori, do you want to start us off?
Sure. And of course, so as a microbiologist by training, I am really excited about the therapeutic potential about the gut microbiota. And what I really would love to see in the clinic is biomarkers, as we talked about, and diagnostic tests to say, we can track your microbiome and we know when to intervene and we know when what we're doing can help you. And really what we touched on today is the advances in imaging technology paired with these new therapies, I think will allow us to track, are we doing a good job for our patients? So to sum up, microbiome, but in the space of these new diagnostics and imaging technology.
Yeah. Great. Nancy, go ahead.
Well, thank you. And really enjoyed your presentation today, Lori. I will say I'm going to stick with the imaging part of things. I'm very excited to have the central vein sign go global, go viral, and be used in the clinic. I think it will be really, really helpful. It will keep people from going off on tangents where they really don't have MS, and will allow us to make a diagnosis sooner. I'm excited about the other imaging biomarkers that we talked about with the paramagnetic rim lesions, and hopefully advances in spinal cord imaging that will really give us great targets that we can approach with all sorts of interventions and lead to better outcomes for our patients. And I will just say that I am very excited about the community. I think MS patients are engaged, they are excited, they are pushing us hard, which we need to keep moving the field forward. So I'm looking forward to great advancements in the coming years. So thank you.
Yeah, great. And then I'll say probably what, kind of like really motivates me kind of on a day-to-day basis is, again, I'll say imaging. So for instance, at MGH, we're using a number of different both MRI and PET techniques to assess myelin and to assess the nerve fibers that myelin surrounds, called axons, and doing this in really kind of like novel ways. And so I'm excited about how we can use these new imaging techniques to assess therapies, specifically this area of remyelinating therapy that we're hoping will have treatment options in the future. So I'll leave us with that, and I'll say those are areas that the McCourt Foundation has supported over the years, and so it's really exciting to have partners that help take these ideas and sort of push them to fruition, really as quickly as possible. So I want to thank the McCourt Foundation specifically for putting this event on each year. It's really, I mentioned, a highlight for me. I know we did not cover all the questions that were asked, so there is an opportunity to spend, for those of you that are here in person. I'll certainly be around here for some time to be able to answer more specific questions. But we really thank all of you for spending your Sunday morning here with us. And we'll wrap up today. Thank you.
Thank you.